Good afternoon, everybody. This is Surgical Information Systems presentation for the ASC month. We have gathered a panel of distinguished guests to sit down and talk with us today about the future of ASCs and some of the proven strategies that these ASC experts have used to advance their ASCs and create a great environment for their patients, a great environment for their physicians and for their staff. So for those of you that don't know me, I am Daren Smith. I am the VP of ASC Solutions here at Surgical Information Systems. I am a nurse by trade. I run a team here at the Surgical Information Systems that consists of a couple nurses that help with all of the clinical workflows in CIS. I spent my career in the operating room and in surgery centers. So we are in charge. My team is in charge of making sure the things that we create are actually going to be useful in the surgery center. At this point, we're going to start with some introductions of the distinguished panel that we have with us today. So we're just going to do a quick round robin. They're going to tell you who they are and a little bit about their background so you can see the wealth and depth, the embarrassment of wealth and knowledge that I have on this panel today. So we'll start with Jen. Go ahead.
Hi, everyone. Thanks for having me. My name is Jen Vallier. I am a nurse also by background, and I've been in the ASC realm for a little over 22 years, 22, 23 years. I've worked in all aspects of the ASC, from the patient care, pre-post, to the OR, to the endo room, to administration, overseeing all of operations, executive director, and helping others in the ASC industry across the country in varying roles. I also have been lucky to be part of the Michigan Association for ASCs, MASA, and been a board member on for them for quite a while. So happy to be here. Thanks, Daren.
Thank you, Jen. Let's go on to Janet.
Hi, good afternoon. Thank you for having me, Darren. My name's Janet Carlson. I'm a registered nurse as well. Uh, I began my career in the ASCs in early 2000, working in the ASC as a nurse and working in all aspects, like Jen said. I have worked through a variety of different ASCs, but most are focused around orthopedics, pain, spine, general, and urology. I am currently the vice president for Commonwealth Pain and Spine for our ASC operations. I am in the process of building 4 ASCs across 3 states right now. So I'm a little bit busy, but I have been a CEO of ASCs, director of nursing, and the one who knows how to turn off the alarm panel or scrub the toilets and plumb them as well. So I think I have a similar experience as Jen does.
Fantastic. Thank you so much, Janet, for being with us today. Lisa, go ahead.
Hi, thank you for having me join. I think I'm probably going to be an outlier, although I am a registered nurse by background as well. I had 26 years in government. So I actually worked at the county level, and I worked at the Department of Health in New York State, where I oversaw regulations, including those for ambulatory surgery centers, CON, and a number of other programs. So I had 13 divisions. I've been working with ASCs, and I'm the executive director of the New York State Association of Ambulatory Surgery Centers, as well as their government affairs person. And I've been working with them as we've been building the society or the association since 2019. So I'm happy to be here. I get involved in all the policy. And for Ambulatory Surgery Center Month, we actually had the governor at one of our newer ambulatory surgery centers out in Buffalo. So thank you for having me.
Thank you, Lisa. Lindsay, go ahead.
Hi, everybody. My name is Lindsay Hanrahan. I'm Vice President of Product Management at CIS. I have close to 25 years of experience in business-to-business healthcare IT. The vast majority of that has been in the ASC space and some adjacent outpatient healthcare settings. But over the years, I've been really fortunate to be able to work with our customers across all of our products and most recently, I have been thrilled to see the evolution and be part of the evolution of our cloud solution. So currently, my responsibility focuses on integration and data solutions across our portfolio, as well as our compliance solutions. And then I also contribute to some of our strategic partnerships. So thanks for having me. Excited to be here today.
Yep, Lindsay's going to be our resident expert here, so she's my ace in the hole when we start talking about some of our subjects here. And rounding everybody out, Virginia, go ahead.
Terrific. Well, thank you so much. It's a pleasure being here. I'm a head and neck surgeon by trade, and I'm now retired from clinical medicine and I'm CEO of Nexus. But while I was in clinical medicine, I co-founded and opened an ambulatory surgery center in the early 2000s and was the managing partner for that for over a decade. And I love the ambulatory surgery center space. So right now with Nexus Health, I'm a CEO at Nexus Health. We do the patient experience surveys, the OAS caps, along with other caps, along with other types of patient experience surveys, and discharge calls to home to make sure everything is going well. So it's a pleasure being here with everyone, and thank you for having me.
Fantastic. So now that you've heard those introductions, you see the embarrassment of wealth of knowledge that I have on this panel today. So what are we going to be talking about on this panel today? We're going to cover as many subjects as we can, but I have 5 main ones that we want to cover. We're going to talk a little bit about market growth and opportunities in the ASC industry, but in healthcare as a whole. We're going to talk about, of course, because it's surgical information systems, we're going to talk about technology innovation and how that is affecting the ASC workflow and the people who work in those centers. We're going to talk about interoperability and consolidation and ownership models and things about how all these people are talking to each other. We're going to talk about revenue cycle and the outsourcing of revenue cycle and revenue cycle management itself. And of course, because I've got Virginia, the resident expert on the line as well, we're going to talk about the patient experience. So with all of those subjects, the first one we're going to talk about is a very broad subject that I'm sure everyone's going to participate in. But we're going to start with Lisa because this probably fits her experience the most, and that's talking about market growth and opportunities. So I'm going to present this one to Lisa first. From your perspective, what does it take to really unlock the full potential of ASCs? Where are we going? Where do we go from here? How do we get there?
So I have to tell you, I forgot to leave something out. I'm also the president of Capital Health Consulting. So just a little thing. So where do we go from here, right? What are we unlocking? I actually started working with the ambulatory surgery centers on this side, so I wasn't in government. And when we started talking to legislators and folks in government, the ones that regulate us in New York State, there were some strange answers we were getting about what they think an ambulatory surgery center is. So our first couple of years was really just talking about what is an ambulatory surgery center. The full potential is, I think we're at the tipping point right now, at least in our state, and what I'm seeing. We're starting to really see a growth of interest. So we started in 2019 where, oh, isn't that where you get a cast done? To, oh my gosh, you actually have real ORs here. Yes, we do. So now we went from, I think, a little over 40 members then to over 120, 130, and we're growing very, very quickly. And the reason is that one, everything is starting to change where healthcare is now, it needs to start to do a better job of managing the money, getting better outcomes, and giving what consumers really want. So that is what's really starting to unlock. Some of it is our doing or your doing, where you're starting to really create what the clients and the patients want. But the other part of this is really on the kind of like pushing on us, right? Healthcare, big hospitals can't be the ones that are running everything anymore. It just doesn't work. The model's broken. So we are getting pushed into this. So we have a little bit of a leg up. And it's one of the largest sectors of healthcare investment across the country. And so that is one of the things we're seeing. There's also a gigantic interest in what are the other things you can do in ambulatory surgery centers, right? And so we're starting to see some of those CPT codes get approved by CMS. That's also going to help us along as we see other types of surgeries getting done. Hopefully that answered that question.
Yeah, fantastic answer. And when we look at this, when we look at the next 3 to 5 years, and I know Janet has a really good pulse on what's going on in the industry as a whole, where do you see the biggest opportunities for growth on the ASC industry?
Right now, I see it with the migration of the higher acuity cases. Like Lisa said, there's how many? 500 and some odd new codes that are coming to the ASC covered procedure list. So that will include a lot of the higher acuity, like total joint revisions, cardiovascular, peripheral vascular, all of that sort of work that has always been done in a HOPD or a large health system setting. That will pave the way. The other thing I think that'll be a catalyst for growth in this industry right now are the site of service shift, the initiatives that are going on to get the better reimbursement at an ASC site of service, looking for site neutrality, where HOPDs have that leveler or their scaler for their reimbursements. We're trying at ASCA, I lobby about this all the time to try to get the site neutrality into being an actual thing. And so that could also help in this market with the pickup, just because we have the same expenses of overhead, labor, supplies, implants. But we're tied to the consumer price index urban, and the hospitals are paid on the hospital outpatient department, hospital market basket. So it's an unfair playing field from the get-go.
Yeah, and that's something that we've been talking about for, it seems like, decades.
It does.
We've been talking about it, and we're finally starting to hear them talk back about it now, where we're getting some of those people educated on, listen, if you have to cover the first $5,000 of your health care, wouldn't you rather have that at a place that A, is more convenient, and B, your first 5,000 is going to be less at the surgery center than walking into the hospital. People are finally starting to get that. And now, that constituency that bubbles up into politics, and we're starting to see them understand what we're here for. And that's all thanks to the people on this panel, the people who are brave enough to get into the political side. I envy that in you, Lisa. I went to, when I was the director of nursing, I went to my first Medicaid open meeting in Nebraska. And I walked out of that meeting thinking, my God, how does anything ever get done in government?
Yes.
And so anyone who's willing to put themselves in that track, I am definitely envious of the people that are willing to have the patience and authority to be in that position. So thank you both for your contributions there, Lisa and Janet. The next subject that we wanted to cover, of course, because we are a technology company, is we want to talk a little bit about technology and what we're seeing in the market and how we're using that technology. So I'm going to direct this one to Jen. I know Jen very well, and her center was an incredible place of technology innovation. And my question to you is what technology in innovations were you using, and what did you see as an impact of using that technology?
Yeah, great question. Most ASCs are still using like a paper format for charting and for regulatory compliance, documentation. And I just call it kind of a Frankenstein. You might have a little software here, you might have a platform here, and how do they talk, and what's the integration, and do they integrate, or are we using it? And so I've had experience along the way with many different types of this. And it's really difficult to say whether clinically, operationally, or financially is like the biggest impact because it's all impacted. And the biggest takeaway that I've taken, let me step back just a moment. So I came from a facility for many, many years that was paper and had very little financial ability to go into improving their EMR system and their technology. And it was very difficult. It's very time consuming. It's very it's very heavy in the amount of man hours that you have, your staff putting into it, yourself putting into it, your reports that you're running are very time consuming, and often you have to be very diligent about making sure that they're, accurate. And so, along the way, we were able to kind of implement, a few things here and there. And then I went to a facility that it was beautiful. It's a beautiful facility, had great equipment, wonderful staff, and all of this technology. And they had the whole SIS package, just to plug SIS here a little bit, the whole SIS package. And they had an inventory management system, and they had, all the different platforms. And none of the platforms were being utilized to their capacity. And none of the platforms were actually integrating and speaking to one another. So we were not able to run a report to tell you exactly what dollar per case cost was per CPT code. We were not able to track how much of a specific item we had in a facility without going and handpicking it. So that was one huge piece, was to try to pull all the technology together and integrate. And so that over even the last 2 years, the advancements that are coming with each platform and each software solution is talking more to one another, working more with one another. They're listening to the vendors, are listening to the ASCs, they're listening to us as administrators, executive directors, clinical directors, and saying, this is not working. How can I not run this? How can I do this better? How can we get anesthesia involved? I need for regulatory compliance, how I need to be able to make sure that a chart does not close if somebody does not do something appropriately. So just the more that you spend time with your software, the more that you spend time with your vendors, the more your technology is going to work for you, and you're going to see huge financial gain. You're going to see way more operability. You're going to be able to have data be very transparent and easy to run, and you're going to improve your clinical operations to make sure that your staff and your physicians and your providers are all meeting all the regulatory compliance checkpoints that they need to be meeting along the way.
Mm-hmm. And we always talk about this too, that over time we've all been required to do more with less. Right?
Mm-hmm.
So how do we do more with less? Well, we have to introduce technology. Well, if we introduce technology, how do we make sure that we still have that human touch? Right?
Right.
I always told everybody that I want nurses doing nursing. I don't want nurses being on a computer. So, so how did you balance that, Jen? How do you balance being innovative and being technology forward, but still having that personal touch?
Yeah, so I would recommend to anyone who is struggling with some of the things that I've struggled with in the past to get us to where we are today, that you really have some experts that really dive into what it is that your platforms and your softwares can do for you, and they are the go-to person. And I do recommend that is not you, executive director, clinical director, admin. You need to have a basic understanding, but you really need to have some people to rally the flag and make those decisions that are on the front line and understand what the compliance requirements are. Because once you do that, if you have your people helping you to create those workflows, and you're involving your physicians in their templates, and you're listening to them say, I can do this in 2 seconds on a microphone and dictate, or I can do this in this many clicks, and I want 2 clicks, not 5 clicks. Okay, well then grab the physician who's willing to sit down with you and say, okay, I need you, physician, to do these things, and you, physician, need what from us to make that happen for you. And so really involve your teammates, and involve the people who are doing the work and having to spend time on the computer, so that it is easy, it is efficient. They're able to problem solve when something happens. The internet goes down, or there's a software upgrade and everybody's kicked out and the passwords don't work. Like, who is that can help to do those? So involving more of your team and keeping it less to just one person in your facility.
Yep, that technology champion probably needs to be in somebody's job description, is what I'm hearing you say. And to follow that up, and I'll open this up to all of our panel members today, is one of the technology buzzwords that we hear a lot about today is AI. What's AI going to do for healthcare? And we are just on the tip of that now. It did get slowed a little bit with some government intervention. They want to make sure that we're doing this correctly, but from that perspective, where do you see AI fitting into healthcare?
I would definitely say it would be some of the physician post-operative templates.
Mm-hmm.
I could see that utilized right away. But it could also help you with the language in your policy procedure manual, or tightening up your job descriptions for the folks in your ASC. Just, I use it for the wordsmithing and making sure that I sound quasi-intelligent. So, but I can see an early adoption for that right away.
Mm-hmm. Yeah, being the tip of the iceberg here, we're really just starting to see some of that, and we're starting to see some of that in creating those appeals letters and creating, dropping all of your data in there and creating that statistical framework you need to make decisions. Sorry, I cut you off there, Lisa. Go ahead.
No, you just mentioned decisions. So I think AI is also going to help when you have, specific labs that pop up, to actually build in the algorithms for some of the decisions and notes that you want to make sure are put in your templates or in your, surgical notes. So that's something that I believe that AI is going to assist, especially the physicians with.
Mm-hmm. Mm-hmm. Yeah, and we're, everybody seems to have it now. They say they have AI, so we're inundated ourselves as a technology company. We're inundated with people wanting, asking us, when's AI? When's AI? What are you using for AI? And the simple answer is, from the company perspective, we're using a lot of that AI integration on the things you can't see. So we're using that to help us develop better help files. We're using that to better diagnose problems when people are calling in to support. We're using those AI things internally currently, and then we're going to be introducing more AI in the usable parts that you guys get to see and use. So great answers. I love to pop that in there because it is such a buzzword right now and such a hot topic. But go ahead, Virginia.
Yeah, I just agree with you that when you start to think about it, it really, almost from like the beginning to the end, you can have AI touch it, whether it's part of the scheduling, part of what instruments are needed, analyzing which ORs, like if you need a microscope for 2 different ORs, if you need on every aspect, whether it's scheduling, the workflow during the surgeries, and then somebody mentioned the post-surgical instructions completely lend itself to it. And I think it's going to be one of these things where we sort of start to think about where we can use it, and then when we're done with it, however many years that takes, it's going to be like have touched like almost every single aspect of it. So it's really exciting.
Yeah, one of the coolest things, I just witnessed this week. We walked into a surgery center and they were taking all of their discharge instructions and dumping them into ChatGPT and said, hey, make all these discharge instructions sound like the same person wrote all of them, and convert our language to be on an 8th grade reading level. And the output they got was incredible. So someone, was looking at that and said, hey, you know what? This is something that not all of us have the ability to make these all sound the same. I'm not going to spend the time going through every physician's discharge instructions. Let's let a machine do that. And I thought it was a very innovative way to use AI and how to get that to give them what they were looking for. So we could spend all day talking about this one, but we were going to have to move on here. So thanks for your contributions there to Lisa, Virginia, and Janet and Jen that jumped in on that one. But now I get to pick on my good friend Lindsay because we're going to talk about interoperability, and we're seeing different things changing as we go through the environment of ASCs. Back when I started in the ASCs, they were all owned by physicians, and there were some JVs out there, and there were some hospital involvement, but that has certainly evolved. And how has that evolution of operating models and ownership affected the push for interoperability?
Yeah, no, it's a great question, Daren. I mean, it's so multifaceted, I feel like, so one of the key things I think is just fundamental to ASCs and always has been, which is just the focus on efficiency and being lean. I mean, there's, how many times you visit an ASC and like the clinical director has had to scrub in because there's this, they have somebody out that day, or somebody's doing inventory counts. And I mean, really just people wear so many different hats that interoperability is a way to make sure, kind of like what we were just talking about with AI, like we don't need to, it doesn't make sense to have people who are, highly compensated, able to take care of patients and deliver patient care, focus on clinical excellence, focus on quality, do something like, create a patient in the system that was already created in a different system. And the chances are through an interface, you're going to actually have a much better chance of accuracy and timeliness, all of that information being captured correctly. And this is like the most basic use case, right? But, making sure that all the demographic data is current, is accurate. And instead, you're just validating that with the patient instead of entering it from scratch every time, because they were just at the physician's office last week or 2 weeks ago, and they just provided that information. So, just at a really simple level, I would say that. But then when you look at, the expansion and the movement toward, private equity ownership or corporate, larger organizations, larger healthcare entities that have bought stakes in or now outright own surgery centers, really what they're looking for from a business standpoint, and really in the end it's about the patients and outcomes, of course, but realistically, right, they're going to put their money where they think it's a good investment. And so really it becomes, how can you really quantify value of that business like any other business? So by having efficiencies built in and simplifying workflows that don't need 10 people to do them every time, not dealing with, printing things out and faxing them or mailing them, and, instead getting them out the door that same day, 5 minutes after the op note is signed, instead of printing and mailing or printing and faxing, or, one of these other like arcane, I'm in 1982 world here that we all still sometimes are in, right? But like just trying to keep that to an absolute minimum adds value and makes us more efficient, makes surgery centers more efficient and just a better investment overall. So, I think just really, I would say the categories are really like the efficiency in workflows. That has so many benefits downstream to, patient satisfaction, revenue cycle optimization, all of those things, scale and being able to replicate similar workflows in multiple settings. So if you are, you have 20 centers and they have, 5 characteristics in common, knowing that you have a set of tools that you can go in and, turn on quickly and easily, and that you know how to support them. And kind of going back to what you were saying with having a technology champion and a leader, somebody who's well versed in those and understands them. All of those are just efficiencies that you can pick up. And then I would say thirdly is, just capturing the data in a clean way. So even with the most simple use case of patient demographics, right? If you have patient demographics wrong, you can end up with denials or, claims issues, all these things downstream that are simple and easy things to prevent, and also help you to make sure that you're capturing your data in a clean way, that then from a reporting standpoint, it feeds into, being able to look at, all of your volume reporting, case costing, like all of those KPIs and metrics that are so important, and that like an investor or a buyer is going to look at and be impressed that you're able to retrieve and show quickly during a due diligence process. And all of our clients also enjoy not having to pull that every time for a board meeting, and having easier access and cleaner data every time also. So I mean, I could keep going, but I see Jen's hand up, so I'm gonna pause there.
I loved everything you said about that, because it is so true. And when you're talking about clean data, I just wanted to say that in a different way for different listeners. That means the quality of the data that you're putting in. So if you have a demographic transcription error, that we already have the information in one system, but you have somebody else that's manually keying that in and it's transcribed wrong, that affects so much downstream. Then if you can just pull it and have the key part of this, everyone needs to hear me say this, is somebody actually has to validate and verify. And if it is not correct, make the correction so that you can continue down. So that's where the time should be spent, is validating, verifying, and correcting if issues, not rekeying in information that you can then make a human error and then cause so much delay down the road. And for the regulatory compliance piece of it, and not only necessarily like the CMS or your own state compliance, but if you're in some of the insurance companies, premier centers, right? And you're needing to meet certain metrics and be able to pull data for certain metrics. I was in an orthopedic center, and so we did a lot of hips and knees. So without saying the name, everyone knows what, Blue Cross initiative I'm trying to, talk about here. So if you do not have that data, then you have to backtrack on so much, and then you're missing out on that revenue source and that reimbursement piece. So if you're able to put into the system already, I need this data in order to board this case, it must be there. It starts from the beginning. It's always there. It's validated. It's verified, and you move forward with it. Then you can spit out those perfect reports. So I was excited about that one. Thanks.
Yeah. Or like Jen, to add on to that, or automatically then send it to the registries if you are participating. If some of them have that capability, some of them don't. But being able to simplify that process even makes it more secure. Make sure it's just an easier process. You're doing it in a timely manner. I mean, the other part I didn't mention, but also relates to what Jen was just saying too, is just being able to confidently say that you can hook into the broader ecosystem that, a larger healthcare entity or, a hospital system in your community, an HIE, any of those organizations is really, I think, a key asset, and important to be able to, it used to be that, ASCs were, like you said, Daren, at the beginning, you were on your own using paper, and really we're at an interesting, position in the patient journey. Like, we do deal with hospitals, radiology, labs, practice, like all of these different entities. And so given that there are just so many tentacles out in the surrounding ecosystem that have opportunities for us to be able to share data with.
Yeah, we as an ASC, we don't have to be an island anymore.
Right,
We
exactly.
used to be that little island out there
Yeah.
that was kind of on its own and kind of feed and grow itself. And
Hmm.
now we can be part, because of that interoperability and crossing those challenges and overcoming those challenges, we can be part of that full healthcare environment. And that's the exciting part that we see from surgical information systems and from an ASC perspective too. When we talk to people at ASCA and stuff like that, they're very excited about us being part of that healthcare continuum instead of being that little island and that little episodic center that we went
Exactly.
to once 5 years
Yeah.
ago. We're now part of that whole healthcare picture. Virginia, I see your hand up. Did you
Yeah,
did you want to
thank you.
contribute there?
Yeah, just to say, well, it's so true, just to like a little island that's just like hoping that everybody else is also giving the correct information. You're like sort of like, please hopefully give the right information. And I'm also thinking about how you could even tie AI into that. I mean, I remember uh, from the surgical offices, you're relying on they're giving you the correct surgical code of the surgery that they're actually going to do. So they're like you're relying on that surgical code to prep for it, pull the right instruments, get everything ready, know if you need something special that to order and so forth. So you're relying on those codes, and then you're also potentially relying on, okay, so they give you a code, they give you potentially maybe they give you some instruments that they think they might need for it. And then if it contradicts, all of a sudden they're asking for like scopes to do for like a endoscopic hernia repair, but then they give you a code that's not endoscopic. This is where AI I think would come right in and be like, wait a second, wait, does not compute. Which one is it? So we can actually prep you and have your case ready for you and not have you be like screaming at us. So I think all of this interoperability becomes so key that all the communication, and it brings you back to where everybody has said, everybody wants the clinician to work at the highest level, but like Jen said, to not be worried about duplicating everything, but just check, just to verify and have that AI come in and help verify, I think would be great.
And I know, Lindsay, you have a lot of experience with this. You've seen probably thousands of different integrations with health systems and HIEs and equipment and all of those things. When an administrator is trying to pitch an interface to their board, what
Hmm.
would you say, give them some ammunition to say, these are some of the measurable benefits that we
Hmm.
can see from making this investment in interoperability?
Yeah, I mean, I think honestly, I could go on about this for a long time, so reel me in where needed, Daren. But I mean, the most fundamental is just looking at like, okay, it's like any process assessment, right? Like how long does it take to do this process today? And then looking at, okay, I'm going to be able to eliminate or reduce steps X, Y, and Z. And then the future state process, oh, look, now this, 7 minute, I mean, often legitimately, this is often the like real time frames that we would expect to see, a 6 to 7 minute process reduced to like less than 1 minute, or 30s, which that less than 1 minute is also just the confirmation of the data, making sure that we're not saying like nobody ever looks at it or anything like that, but it's just pulling up the patient data, reviewing it, making sure that it's accurate, and then hitting save. So it depends on the workflow, but just as a very basic example, it really is a simple calculation of just looking at like what's the current state compared to the future state, and then how often do you do that task. So how often do I do it, and then the other component, so then you get your time savings, let's say over the course of a month, let's say, and then you can factor in who is the person that's typically doing that? What is their ballpark? What are we paying that person? That's the hard measurable, dollar amount. But the part that's a little harder to quantify is, I think, because no one's making the argument that, oh, Sally at the front desk is not going to be there anymore. I mean, of course she is. But the benefit is, what could Sally be doing to better contribute to the patient experience, to making sure that the providers are happy when they come in, to making sure the environment is nice, following up on phone calls, like all of the other value that that individual, like to go back to the earlier conversation about the human touch versus the, versus technology, that you're using your humans in the best possible way and leveraging that human touch as much as possible in each of those instances. So that's a little bit of a harder number to quantify, but I think is really important to at least try to articulate, along with the hard number of this is the potential time savings, this is the potential dollar savings, because it really does make a difference. And I think in many ways it's, just as important, because it does feed into patient satisfaction, provider satisfaction, overall quality. That person has more time to be sure that other things aren't being missed or forgotten about during the course of their day. So, just a really, really, really simple framework. I'll pause there, but it's really, the math usually comes out to be the return on investment is really, really substantial. Depending on who your vendor is and what they're charging, obviously, but if you're looking at like an additional monthly fee for an interface that is going to save you, hundreds of hours of time and give you a person's attention back on patients, it's hard to say that it's not worthwhile.
Excellent answer, Lindsay. Jen, you were going to jump in here too?
Yeah, I just want to say from experience too, what it also does is, the physician investors also are typically practice investors. And so when you have interfaces that are positively affecting the surgery center, they're almost always positively affecting the practice as well. So it's helpful to kind of bring into aspects like, okay, your op notes that you're doing here at the surgery center, if we have an interface that goes back, not just from your facility or from your practice to us, but also back to your practice, all those op notes can just go right into your chart. You don't have to carry them. You don't have to have people asking for them.
Point.
And, so it's usually what's helpful for the facility is also going to be helpful for the practices. And so that's a benefit that that is often overlooked, I feel.
That's a really great point, Jen. Thanks for mentioning that. That is really key.
Yeah, I'm almost embarrassed to say how much money I spent on labor faxing, that's how old I am, faxing op notes back to physicians' offices. And how excited, once again, how old I am, how excited I was when we got the interface for the zip codes. So when I put in the zip code, it automatically puts in the city, state, and county. I thought that was an innovation that was going to change the world. And that was just the tip of the iceberg, because now we once again have been able to take ourselves off that island and envelop ourselves in that healthcare continuum. And yeah, we could probably talk about this one for a while. Virginia, go ahead. I'll let you jump in here, and then I'll move to the next one.
No, absolutely. It's so true when you talk about like making the physician offices happy, because let's face it, that scheduler potentially is the same person that's getting those op notes back. And that scheduler usually has a choice of where to schedule that surgeon. So the more you can make the office happy, and the more you can have a little like, that was easy button, like, oh, that was easy. The more like everything just flows, and before you know it, you're more cases. So like there's the return on investment is certainly going to be significant there.
Yeah, there's a lot of tentacles associated with an interface, and we start talking about how that can affect patient satisfaction and physician satisfaction. And as we know in the ASC industry, we've got two sets of clients. We are serving our physicians and our investors as well as our patients. So the more we can reach those tentacles out and use technology, innovation, and interoperability to advance that, the better off we're going to be. And I know we could talk about this for a while, but we're going to move on. So the next subject that we wanted to cover was revenue cycle management and outsourcing. And Janet, I'm going to tap you in here. Where do you see outsourcing, either or full or partial outsourcing, that makes the most sense in the ASC industry?
That's a great question, Daren. I don't think there's a one size fits all decision for ASCs, honestly. I think the choice needs to come between either full or partial outsourcing, depending on the operational complexity of your cases, the acuity of them, your staffing bandwidth, your strategic priorities. So I would say, for example, partial outsourcing, that would allow you to have targeted efficiency, but you don't lose control. So I would think some people would choose that, but you must have a competent in-house billing team. That is an imperative. And so that's why I led with the bandwidth part first. But those are the folks that can handle the pain points for billing for anesthesia, meaning the coding, the denial management, the collections. And if you're billing for anesthesia, the specific coding and then the time intervals, that's a completely different can of worms, proverbial worms. And if you're expanding into new service lines, say, if you haven't done outpatient total joints or spine or cardiovascular, that requires a specialized coding team experience as well. So those are some of the considerations if you want to keep it in-house. But a lot of the commonly outsourced functions, I think, for the partial option is with coding, primarily patient collections, and then claims follow-up. So I think that works if you've got the bandwidth and the strategic control to offload some of those things, but still have some of it in-house. It is scalable, it is cost effective, but with your fluctuating volumes, and then if you have, like I said, the limited internal staff for your business office, that would be a reason why partial revenue cycle management probably is not a good solution for you. The other one is fully outsourcing it. So that way you're end to end all the way. That's typically best for those ASCs that are struggling with a lot of turnover, staffing shortages, a lot of concerns about compliance risks. That's another thing. So if you want to focus just on the clinical outcomes and the experience for the patients, for the surgeons, for your team, that's when maybe fully outsourcing it would be a good strategic initiative for you, so you can put your energies into the one basket that really is going to make the most impact the quickest.
Yeah, help me take off one of those 10 hats that I'm wearing.
We
right?
all spend like 75 plates at the same time when we're running an
Exactly.
ASC, and that's on a good day. So if I can take a hat or a plate down, that'd be great. And then if you're experiencing rapid growth and you need an infrastructure that's scalable, I highly suggest you outsource it, because it's so much to keep up with. And it's not necessarily any mistakes that are intentional. It's more, I think, omissions. It's just you don't have the full knowledge to do it compliantly or accurately. And so when you outsource it that way, you can improve your collections. You can also drive for faster reimbursement payments, just because some of the specialized tools that some people offer to do so. Again, I keep going back to regulatory compliance. That's a big thing in billing and coding, scalability. So, I mean, that's an industry snapshot. I think with just the partial or the fully outsourced. But right now, quite a few ASCs will outsource their revenue cycle, but there's an increase, I think, in those wanting to partially outsource and take some of the control back in-house. I think that is a trend that's rising as the rest of the ASC industry is shifting right now in general. So hopefully that answered the question accurately.
Yeah, and when we look at it too, I would challenge you right now, go look at Indeed, go look at every single hospital's website Go look
Right.
at every single large ASC
Mm-hmm.
conglomerate, and what is the number one job that's posted? Coders.
Absolutely.
Coders
100%.
and follow up, and the demand for those has skyrocketed, and we
Right.
don't see as many places training that, and we
Mm-hmm.
don't see as many of those people in the market. I mean, I was spoiled where I was at.
Mm-hmm.
We had a women's prison that was in the next town away from us, and that was one of the programs they had
Oh,
there
wow.
was medical coding and transcription
Mm.
programs.
Right.
So I had a wealth of coders that were looking for jobs, but not everybody had that. As I started to expand my
Mm-hmm.
reach and look at other areas, everybody was looking for coders or looking for follow-up people, because what's the first answer you get from any insurance company? Denied.
Denied.
So,
Right.
once again, that takes time, energy,
Sure.
and effort to get the money that you deserve. And not all of us have the experience to
Mm-hmm.
know how to do that quickly. And hopefully, these outsourced options that we use are experts in getting that in an efficient manner.
Right.
Um,
And then, back to what everybody on this panel has already discussed, but it bears repeating for this topic specifically, is with a lot of the ASC covered procedure list additions, and then preparing for the inpatient only phase out process, we're going to have all types of procedures and higher acuity things that nobody has experience with in the ASC because they've not happened before. They haven't been done before. So you're going to see the need not only for the coders, but the specific acuity or service line so that they understand the ins and outs of spine, cardiovascular, orthopedics, total joints. That is paramount to your success. So I just think you have to be smart about where you're going to put your resources, obviously, as far as doing it partially or outsourcing it. But then if you do decide to one of the other two options, you just have to make sure you have the right partner. That's a very nuanced conversation, but you all have to have the same goals aligned. You want to be a partnership and not a vendor. And that's the difference. You both can win in a partnership, understanding what your financial goals are and all the nuances of outpatient ambulatory surgery.
Mhm. And from your experience, Janet, what makes that? I know you've done all three of those. You've done in-house, you've done partial, you've done
Yes.
full outsourcing. What makes that relationship successful?
Constant communication, over communication. The communication of, hey, Janet, your aging AR is this, and would you like me to spend time on this, or do you want me to spend time on your new, higher acuity cases? And so you're having to make decisions like that, and what is worth the effort. And so I think the communication in some of the KPIs that you would be looking for as an ASC leader, just to know that, okay, this is what our reimbursement rate is with this payer, or this is the short period of time that they pay, or this one is now picking up on their denials, or now they're just continuing to want to send you, the denied, and, oh, we need more records request. So that communication of trends that you see occurring in specific to your account, and having those common key performance indicators, your dashboard of how much do we have in our aging AR, and what's our 30, 60, 90, 120? What does that look like? How can we whittle that away, but also stay on top of the current volume that you have?
Mhm. Fantastic answer. Thank you, Janet. Virginia, you had your hand up.
Yeah.
You want to add to the conversation?
I just wanted to add, I agree, there's so much complexity to coding. It's almost like, it almost starts to feel like the tax code, It's like, it just gets more and more complex. And just when you think like, maybe we can make it less complex, they make it like 10 times like more complex. It's like, so the coding just becomes more and more and more complex. So the level of expertise is real. It's not like, oh, you can just sort of like wait, you really need that level of expertise. And then, like Janice, I think it's so important, the communication, whether you have it in-house or external. It's hard for me to think all in-house makes sense, but obviously everybody decides that for themselves of what their level of expertise that they're really able to hire versus outsource it. But the other portion of communication is that the patient responsibility portion is just, for some places, very significant. And that communication, I won't go into the patient experience portion yet, but
oh, that's a good transition. We're going there next. So
the communication of a patient responsibility portion prior to a surgery is huge. And it's something that, I mean, obviously everybody wants a good outcome surgically, of course. I mean, that's the most important thing. Am I surgically good? But also, if you're not treated well with the patient responsibility portion, and if a patient's not given full notification up front, it really hurts that patient experience. So whether that becomes your internal person with your vendor, or your vendor does all of it, whatever it may be, just the communication is really strong. And of course, getting the money in the door, so we have the KPIs for your accounts revenue. Of course, that's important. But at the end of the day, also having the communication with the patient is key.
Yeah, and that you transitioned me perfectly. Lisa, did you want to hop in there?
I just wanted to actually play you for a second and ask a question to the panel, which is some of the questions that are coming up. We talked about partial, outsourcing, but have you started to see where's the AI with this? And that has been a question that's coming up. So I was just wondering if anyone can add to that and answer that, if you're starting to see it, because we have people that are looking for that now.
I see it when I'm pitched all the time from different companies, and they are talking about when the case is booked, they use AI to start working the denials on the back end. So I think that's something that is attractive to all of us because they're anticipating the denial. And so what can you do to get ahead of the arbitration of that? I think that's a key message that I hear on the 57,000 LinkedIn. Here's your solution, and I'd like to share it with you. Can I get on your calendar? But I think that's a great point, Lisa, and I see where that you could start working those claims already in an anticipatory fashion.
So that might be another session. I'm just
I
asking.
agree. Totally.
It's going to be,
Yes,
it's a big issue.
It is.
Thank you.
And as surgical information system progresses in their AI journey, we probably have the biggest bucket of data that could ever be submitted to AI to learn those things. So from a company perspective, that's where we're going to go with this, is we have all the data to teach our AI, and that's where we're going to use our influence to get that better outcome, to get that faster payment, to get that denial turned around. And because if you think the insurance companies aren't using AI right now, you're absolutely mistaken. So we're going to try to get you caught up. So Virginia already teased us a little bit with the patient experience, and that's the section we're going to go to next, and we're actually going to direct this question at Virginia, because quality outcomes and quality care have always been the hallmark in the ASC, right? And as we have all talked about, the expansion of procedures and the expansion of specialties and all these higher acute care patients that we're dealing with and cases that we're doing, what are the best practices that we can use to maintain that high level of quality and that high level of outcome?
That's a great question. That's a great question, and it sort of incorporates everything we just talked about, because at the end of the day, everything to some extent touches that patient experience. So I'm going to give you my answer. Then I am curious to see some of the panelists who are sort of doing that at this exact moment and bringing things on, you know? So what I would suggest, sort of from my previous experience and my experience, is that if you're going to bring on new cases and you're going to bring either on high acuity, whether maybe it's higher volume, maybe it's just a surgeon came in and it's the same thing, but it's just like a tremendous amount more volume, or it's higher acuity. Whatever it is that's going to sort of tax your workflow, really sort of be honest with it, with the leadership, with your key stakeholders, your leadership, your middle management, and then even your front end people on what is going to get taxed, what is going to get strained, and what are you going to do about it. So I would start off with, what characteristics are we currently the strongest with? Do we have a great timeliness of procedure? Do we have a great experience with the front desk? Do we have nurses who are super attentive? Do we have recovery room nurses that are very attentive? Do we have surgeons that don't stray and like they help with the turnover, being good and not bad? You know, like what do we have that's like really good right now? What are our key things? And it doesn't have to be everything, but what are our key things that we think are really good and we want to be sure don't get too disrupted, although they are going to get disrupted. And that's the other piece, is to actually just come right out and say they're going to get disrupted. We're bringing on cardiac, we're bringing on total joints or something. Like, it's going to get disrupted. And all of you already, like Janet said, are spinning like 75 plates. And so gently sort of let them know there might be a few plates you're spinning, but we're going to help you because we're going to bring in interoperability, and you're not going to be keying in demographics to somebody, and you're going to like have this other help, because we recognize that as we're growing, we also need to give you the tools to be able to grow. But first, recognize what really strengths are there in this particular ASC. What really are the strengths? Getting your key stakeholders, and then at least know what's going to get disrupted. And then, is your inventory going to blow up, or, what is going to get disrupted? And then of course, have some solutions in place with all the key people that are part of that solution. But I would just get out ahead of it and not pretend like, oh, we're going to be fine because we've done other great things before. It's like, okay, that's fine, but let's really define it and get ahead of it and get some solutions for it.
Hope is not a strategy.
Hope is not a strategy. It's not bad to have, but it's not a strategy.
How about you, Janet, Jen, Lisa? Do you want to jump in there? And she was interested in hearing your perspective as well.
I mean,
go ahead, Jen. Or Janet, go ahead.
Sorry, just picking up on what Virginia said. When you're bringing on a new initiative, new expansion, new procedures, you really need key stakeholder champions. So you need somebody in the preoperative area. For example, if you're going to start doing a lot of orthopedics that require general or regional anesthetic blocks, that's going to be a work change in pre-op, because you're going to need the anesthesiologist to do the block. You're going to need a nurse to do the conscious sedation, and that takes a nurse out of the workflow in pre-op. So, for example, a solution is just to have a block nurse for those days, while the pre-op nurse can continue to do her checklist and get the patient ready for wheels in time. The other thing in the OR is somebody to champion it back there, because we know there's different dialogues constantly running in these different areas clinically. And so if you have these champions aligned in the OR to say, you know what, I know this is tough and we're learning something new, and we're going to be doing total joints, and we're going to be putting in, a different type of anesthetic, whether we're going to use local, if we're going to use a spinal, that change has to be championed in the OR, and then again in the PACU, because now with these potentially higher acuity cases, you've got a throughput time, you've got longer patient stays, and so that's going to impact your OR turnover times, your staffing, your hours for labor. So you need champions to be there in the trenches every day, preaching the good word and encouraging all the small wins. And I feel like what Virginia said, it's imperative to have that communication and understanding, okay, here's what we got to do, but we can't just throw it on the team. We have to make sure everybody has the information, the training, the tools, the technology, the equipment. There's a lot that goes on to just adding more, whether it's volume, acuity, more, another surgeon. You can't over communicate enough.
Yeah, and
Jen,
I
go
would
ahead.
just say,
Yeah.
yeah, thank you. I would just say to that too, that back to a previous conversation, we aren't islands anymore. And so it's super important for ASCs to recognize that we are our own network and we have wonderful resources within our network, and we need to be able to use them. And yes, we may compete over, this case goes to this facility and this facility, but when it comes down to it, we are here to help one another. We are here to make sure that we're all doing the right thing for the patient, that we're giving them the absolute best patient experience that they can have. Because if the patients are happy, the surgeons are going to be happy, staff's going to be happy, the owners are going to be happy. It's all going to transpire. So when you're starting something new, don't think you have to do it all by yourself. Reach out to your partners. Reach out to your state associations. Reach out to ASCA. Reach out to your vendor partners and say, Daren, I don't know how many times I've said, Daren, who's doing this? Bruce, who's doing this good? Who do I need to talk to? Who do we need to send somebody to? Or and on the flip side, be willing to host when you do something really, really well. Be willing to take the time to allow someone else to come in and see that transpire, because you don't have to start everything from scratch. So utilize your resources just for IT, not just for IT, but also for the experience that you can provide to everyone in the facility.
Go ahead,
So I'm
Lisa.
gonna just, yeah, I'm just gonna raise my hand because my little button's not working. So you're getting the old-fashioned one.
No
But
problem.
I cannot say enough about what you just shared. Right now, one of the things that, at least in New York, the community that we're trying to do is kind of build peers and to talk about some of those wins together, like whether it's on a call, a monthly, whatever it is, right? To start to share that and help one another. It's really made a difference, and we're trying to do it regionally. So I can't say enough. And going back to community, and going back to just before like around the pandemic, when New York, as everyone probably watched, our governor at the time talking about what's happening with New York, no one was asking the ambulatory surgery centers about some of the things and where we could help and some ideas. And finally, they realized, well, we're running out of sedatives that we need to get people onto vents. So, hey, wait a minute, what is about these ambulatory surgery centers over here? And at that point, we became relevant. And now we have a place at the table for all things going on in the community. So I can't say enough about where I do believe ASCs are going, because they're getting recognized, at least I know in New York State, they're huge. And people are starting to come to us for some assistance and go to each other. So thank you for adding that comment.
That was fantastic. I couldn't agree more. When I first became an administrator, I couldn't have done it without the help of the four other administrators that were around me. Bouncing ideas off each other,
Mhm.
using that information to elevate the patient experience for
Right.
every patient, not just the patients that walk through my door.
And
Excellent.
don't forget those important times when your sterilizer goes down. Um,
Yeah.
those relationships will help you not cancel cases, because we know the mantra in ASCs: never cancel cases. We do
Hmm.
everything we can to never cancel. So that means I'm driving trays in the middle of the night to get them done. Then that's what I'm going to do, and I'm just going to reach out to folks like on this call that are my village, my community, to say, hey, we have the ability to do cases, but I've got a sterilizer issue and I don't really have a solid backup. So I want to make sure I have all the trays necessary, everything ready to go. And I mean, even just operational challenges like that are key to have those relationships, like Lisa and Jen pointed out. That's very important.
And seeing that we have 5 minutes left in our conversation here, I just want to present one last question to each one of our panelists here. And I'm going to ask you to do a little pontification here and look into the future. And I'm going to start with Jen, and we're going to go around the horn here. But I want you to tell me, give me something as an administrator that I can use to elevate my patient experience, because patient experience, we've been talking about this for a long time, is becoming more and more important. And we've seen it grow slowly, a lot slower than a lot of us would like, because we know how excellent the work is that comes out of our surgery centers, but we are seeing it creep in more and more and more. So what is the one thing that you could tell the other administrators, directors of nursing, and business office managers that are on the call right now to elevate that patient experience?
Yeah. I have always been of the philosophy that we want to treat others as if they were our family members coming in the door. And so if we just keep that quality initiative, at the forefront, and that is going to make the difference in the long run. That's my first mantra. The other thing I would say, though, from a technology standpoint, is that you need to know what the requirements are, and you need to know what a patient wants. And so if you are not looking into this, if you are not researching the patient experience, you need to put somebody else in charge of that ASAP. Get a champion, a physician champion and a employee champion going in that direction.
Couldn't agree more. Janet, you are next.
I was going to say that you actually need to be mindful of the feedback you get from your patients in your post-op satisfaction surveys. Sometimes they're painful to read. They're not the feedback that you would desire. However, that's the most actionable information that can help you right there change something that you weren't even aware of. So my admonition, if I could, to everyone in this community is actually listen to what the patient has to say. Follow up with the patient, express gratitude for them choosing your ASC, because they are your best free advertising out in the community. And so just don't forget that there is something important about what the patient has to say, and then validating it and giving them the feedback that you're closing the loop and you're coming back to them with solutions, or giving them an update. I think that's important.
Virginia, you're next.
Terrific. Yeah, I'm just going to jump on with the patient experience surveys. As an OAS CAPS vendor, which is certainly new to the to the ASC space, like Janet said, people ask us, well, what do we do now? We're getting this information back, and what do we do with it? And so one of the suggestions I have when you look at your OAS CAPS surveys, you can't necessarily change everything, but look at one area that you're potentially scoring a bit low on and focus on it for 2 to 3 months, and then look at another area. So for example, one area might be, does the patient feel like they're getting all the information they need about anesthesia? I'm sure they are getting it, but do they feel like they're getting it is one area. So it's just really looking at those surveys and recognizing that you can't necessarily change everything in there. They're a very broad survey that doesn't necessarily, for some ambulatory surgery centers, some of the questions don't feel that relevant for them. So sometimes it can feel like a real but they're not going away. So my suggestion is to take one piece of it and try to implement it. Take the comments, if your vendor allows for supplemental surveys, that supplemental questions, that there's some comments there. Take those comments and really do take a look at that and see what actionable items would be there for that.
Excellent answer. Lisa?
I was just going to say
Is there
communication.
anything we didn't cover?
Now, I think one of the things I wanted to go back to with patient satisfaction is, believe it or not, as a nurse, I still get complaints sometimes. And I think one of the most important things, you've all touched on surveys and everything that's important with quality outcomes, but communication and actually trying to make sure that the patients understand it. Recently had a patient that's on a GLP-1 that went through everything they needed to do for pre-op, only to get canceled because he didn't stop the GLP-1. And it was like, well, it wasn't in my paperwork and it wasn't in, right? So we told you. It's like, well, I was running to the car and I didn't hear that. And so that has come up a couple of times now, is really not understanding the pre-op. And that's been something that's come up to me as just an executive director of an ASC association. So can't say enough about that. The other thing is, if I was to say where I see ASCs being, I see them being even bigger, maybe in the end, toward the ends of our lives, maybe as things go on, and the hospital starting to work and get smaller and shrink with the overnight stays. So that's something that I'm seeing. Maybe part of that is hope, Virginia, but I do think that might be something that we are going to see due to the economics and the changes in medical advancements.
Lindsay?
Sure. I'll just say a lot of great feedback already, so trying to not completely overlap, but I would say just making sure that we talked about networking and leaning on your others in your community and everything. And I know I'm biased in saying this, but, lean on your vendors for that also. So sometimes we find clients they're not sure what they are asking for or need, but if you're working with a vendor, whether it's CIS or a different vendor, reach out, see, explain what you're trying to accomplish to help patients and what area you really need some additional support, brainstorm with them and see what they're able to offer you that can come up. Because I think that, not to say that technology is the answer to everything, because certainly it's not, but I see it more as a vehicle to empower your people, who then are the ones that are really delivering the care that is going to result in a positive experience for patients. So, not having your team distracted by every thing that's going on around them, and really being able to focus on eye contact with the patient, talking to the patient, making sure they're not forgetting anything, because you're maximizing the value of what you have in place and you're using all those tools effectively. I think is, again, knowing I'm biased from a vendor perspective, but sometimes things may come up that vendors can help you with that isn't immediately obvious. So including them in your community of what other tools can help you get there, so that your people are free to deliver the best care possible.
So you guys believe me now that we had an embarrassment of wealth of knowledge in these 5 panelists that we had on today. So I just want to take this opportunity as we wrap up today to say thank you to Jen, Janet, Virginia, Lisa, and Lindsay for sharing your expertise and knowledge and helping to build that community of people who are creating a great patient experience for our patients and serving healthcare in more than just that island. So that wraps us up for today. Thank you everyone for joining us. Thank you to my panel members. We could do this for another hour, I'm sure.
Easily.
But happy ASC month to everyone, and please tune in for future thought leadership sessions here at Surgical Information Systems. Thank you.
Thank you.
Thanks, everybody.
Bye.
Hi, nice meeting everyone.